And here is your question. Right, so if you have read and understood, kindly begin your examination station.
Yes, I will start. Wash my hand. Good morning. I'm Mr. Ghazir, one of surgical Dr. Z. Can I confirm your name and age, please?
Yes, Tom, 56 years old.
Hi, Tom. Today I'm going to examine your legs. It will include look, feel, movement, and may need some special test and ask you to walk. Do you agree with this?
Yes.
Okay. Do you have any pain at the moment?
No, not that much.
Okay. If you don't mind, can you roll up your short, please?
Okay.
Firstly,
Okay.
if you don't mind, can you stand up for me with crossed hands for me, please?
Yes.
Yes. Can you take few steps to the wall of the room?
Okay.
Then
Yes.
turn around and come in your heels, then heel to toes, then on top toes. Okay.
Okay. Okay.
Okay, thank you. So now you can close your eyes and I will support you if you swing to any side. Okay.
Okay.
Okay. So now we will start examination on the bed. Can you can you lay down on the couch, please?
Okay.
Okay, so I will start by general look from the end of the bed to detect
Yes.
any scars. So I found a scar on the upper part of right leg along
Yes.
the lateral side.
Yes.
Okay. In any muscle wasting or fasciculations or abnormal signs of the skin.
Yes.
This I will go for feeling of your leg, please. I will I will start by feeling along the course of the common peroneal nerve, starting from the lateral side of the popliteal fossa of the right leg till the head of the fibula. Then after that, I will take the permission for the patient. I will feel or tapping over this course to detect any bends or needles or numbness along the distribution of the nerve. And I will ask the patient if you feel any numbness and been tingling along your leg, let me know. And I will compare with the other side. After that, I will ask the patient, I will take the weight of the popliteal fossa to feel any swelling in the popliteal fossa related to the knee joint on the same side, on the other side.
Yes.
Now I'm going to assess the tone of your legs, please. Make your legs floppy for me. I will start by leg roll. Then I will take the weight of your knees as left. Then after that, I will bend your ankle and your knees slightly, make it floppy for me to detect what's called ankle clonus. Then after that, we will assess the power of your legs. And just I will support the other hip joint. I will start by hip flexion. I will ask the patient to lift off of the bed and don't let me to push it down and put in the other side. Then I will assess the hip flexion in form of press your legs against my hand toward the bed. And then after that, bend your knees and don't let me to straighten. And the other, kick your leg against my hand, and don't let me to straighten it. Then after that, I will ask the patient to push your legs, squeeze in as an adduction, and squeeze out apart as an abduction. Then after that, as regard the ankle joints, I will ask the patient to push the foot toward his head, then push the foot like a pedal downward, then extend or push your big toes toward the foot. Then after that, I will ask him to push the foot inward, the inversion, and outward against my hand, the eversion, with support of the lower part of the leg with the other hand, and to compare with the other side. Then I will go to assess the reflex, ankle reflex, and the knee reflex, exposing the quadriceps and the calf muscles, making the ankle floppy. This and the Babinski to exclude the central cause in form of flexion rather than extension to exclude the central cause. Then coordination, we ask the patient to put the heel on the knees, run along the chin, keep going as fast as you can. Then I will start to detect the sensation in form of central point in the sternum by cotton. Then every dermatome from up down comparison with the other side, and ask the patient to say yes if he detect and it is equal on both sides or not. Then I will complete with pinprick evaluation at the same cotton tip examination. Then after that, I finish my examination. I will thank the patient. I will ask him to, you can dress now and wash my hands. And I will tell the patient, I will pass my notes to my consultant, figure out your issue, may arrange some investigation to fix it. So today I examined Tom, 56-year-old male patient, presented after stab avulsion vascular varicose vein surgery. On examination, the patient seen with high stable gait, with difficult walking on the heel. This on inspection with scar on the upper part of the right leg, with tingling on tabbing with no detected swelling either along the course or the popliteal fossa. Otherwise, on examination, tone is well and good, away from weak dorsiflexion and version. And regarding the leg big toe extension is weak, ankle reflex is intact, especially the negative Babinski, with deformity in form of equine varus. Sensation is impaired along the dorsum of the foot and lower third of the leg. So my top differential diagnosis is foot drop due to mostly common peroneal nerve injury after stab avulsion of the incision, but I would consider the other causes in form of sciatic nerve injury. With common peroneal nerve division affection, L4, L5 disc herniation with impingement of L5. Other causes in form of central cause as Parkinsonism, cerebral stroke, but it is negative Babinski, and also metabolic in form of diabetes and alcohol misuse.
Can you please tell me what investigations would you carry out?
I will start by electromyogram, nerve conduction study, MRI spine to exclude central cause, also X-ray hip and femur to exclude any bust fracture, and the metabolic in form of diabetes and alcoholism. Vitamin B12.
Can you tell me what management would you consider for this patient?
Yes, I will start by discuss the patient in MDT team, including the neurology and physiotherapy. So I will physiotherapy may be needed, but foot orthosis to prevent swinging during walking and for support. Surgical treatment in form of surgical exploration, decompression, repair, or at the last tendon transfer to the another group.
All right. Okay. Can you tell me what might be the cause of sensory loss in the dorsum of the foot?
Can you restate the question again, please?
What might be the cause of sensory loss of sensation in the dorsum of the foot?
Yes, due to common peroneal nerve injury, deep peroneal affection, due to loss of sensation over the dorsum of the foot and the lower third. and lower side of the
Anterolateral. Yes, anterolateral
lower
aspect
side
of the lower
of the leg. Yes,
yes.
anterolateral lower side of the leg. Yes.
And because of injury to the peroneus longus and brevis, there'll be
Eversion.
weakness in
Yes.
yes,
Loss of
weakness in
eversion.
eversion.
Peroneus
Very good.
longus and brevis.
Very
Yes.
good. Very
And foot
How
drop
would
due to
you yes?
anterior group.
How would you differentiate this from a loss of or disc prolapse of L4 and 5 or disc herniation of L4 and 5? When
Yes.
there is, yes.
Yes. Loss of weak hip abduction.
Very good. Very good.
Yes.
Okay. Wow. Okay, and yeah, you'll definitely know how to rule out if there is a sciatic nerve injury or just the common perennial nerve injury.
Sciatic nerve injury will be a history of hip surgery or fracture hip.
Yes, very good.
More,
Or the
more,
fracture
more
of femur as well.
yes, more central, and
Yes.
will be hip abduction,
Very
hip
good.
abduction weakness. Yes.
Excellent. Good. So it was very good as compared to yesterday ones. One thing again you have forgotten. Once you start palpation, you didn't you. I thought you are going to say it because you did say that you will palpate and you'll go for the. But then you, instead of talking about the temperature, you talked about the tenderness. So temperature, you have to feel it on both sides, especially
Temperature.
yes,
Yes.
temperature. So I was noticing everything. You didn't miss anything except for the temperature. So everything else was good. Sensation when you were mentioning, so you mentioned at the end. So as at least you mentioned, so it was all covered. So it was just the temperature that you have forgotten. But if you'll make a practice, you still had few seconds. So if you make it a practice, you'll remember to include it as well. Anyone else want to give feedback? It was good. No, I guess. Yes. So here is the question. Right. So if you have read and understood, considering its surgical and optimization, kindly
ma'am.
identify the following structures. First, begin with the left-hand side picture and identify, yes, from A to E, please, to F, please.
So, ma'am, the picture.
What are you looking at? Yes.
Yes, ma'am. I am looking at the internal carotid artery and its branches on the right side. Right side.
What
A
is
means,
it? First, please tell me what kind of image are you looking
ma'am,
at?
it is a cerebral carotid angiogram.
Very good. Now,
with contrast study, and here number A is, ma'am, right-sided middle cerebral artery. B
yes.
is right-sided internal carotid artery. D is, ma'am, right-sided anterior cerebral artery. F means first division, and F is anterior cerebral artery second division, and C is, ma'am, the lenticular striate branch of the middle cerebral artery.
Okay,
and,
for those who do not know, can you please tell me also how are you differentiating it? It is on right or left?
So first of all, ma'am, in this picture, it's written right, first
Very
of all,
good.
and
This,
yeah.
Yes, you have to mention that.
And yes, and here actually, ma'am, on this axial or this axial or this coronal angiogram,
Yes.
whenever we just see it's on the opposite side actually. So first of all, as it is on my left side, it will be on the right side of the patient, first of
Yes.
all.
Yes.
So it is on the right-sided cerebral angiogram we are seeing, and the number E means, I think, ma'am, it is a frontopolar arteries
Okay. Good.
arising from the anterior cerebral artery.
And then on the right-hand side picture, if you can also identify from A to E.
Yes, ma'am. On the right-hand side, the picture actually showing mainly the branches, internal carotid artery, and these branches mainly the middle cerebral one. So here number A is, ma'am, ophthalmic artery, the first branch of the internal carotid artery. B is the fifth part of the internal carotid artery. C is the first part before entering into the cranial cavity, the internal carotid artery. E is the cavernous part of the internal carotid artery, and D is actually pericallosal branch of the middle cerebral artery.
Okay, can we move on? And can you identify these from A to E again, please?
Yes, ma'am. I think it is a cerebral angiogram in sagittal plane, and it is mainly showing the branches and division of the vertebral artery. B is the vertebral artery. C is the some muscular branches of the vertebral artery. Then A is the basilar artery. C is the superior cerebellar artery. E is the anterior inferior cerebellar artery.
Okay. Can you please identify this?
Yeah.
What kind of image that is, and what are you looking at?
So, ma'am, it is a cerebral contrast enhanced angiogram,
Very
actually focusing on the circle of Willis here.
Very good. Why is
So
it called
here-
circle of Wills?
Because, ma'am, it actually makes a circular structure from the branches of the internal carotid artery, and also by different other branches of arising from it, ma'am. So here it is, and actually it's surrounds the central portion of our brain and the brain stem. So it's called, ma'am, the circular structure is called circle of Willis, as
So
far as I
what
know.
are the branches, or how is the circle of Wills formed?
Yes, ma'am. The circle of Willis form, actually, ma'am, the number A is here internal carotid artery and its branches that are the anterior anterior cerebral artery, anterior communicating artery, internal carotid artery itself, and then the posterior communicating artery and the bifurcating point of the basilar artery into posterior cerebral arteries, ma'am.
Okay, have you identified from A to
Number A is, yes, ma'am. Number A is the internal carotid artery itself. B is the anterior communicating artery. C is the anterior cerebral artery. D is the middle cerebral artery. E is the basilar artery, and F is the posterior communicating
Very
artery.
good. Okay, moving on. What are you looking at? What is this arrow showing?
So, ma'am, I think it is a cerebral angiogram, contrast enhanced angiogram, and actually it is
Yes.
focusing on the right-sided middle cerebral artery aneurysm.
Aneurysm. Okay, in what kind
Yes,
of
ma'am.
conditions do you find this?
I think,
Aneurysm?
ma'am, most commonly it is associated with the genetic disorder, the polycystic, associated with
Very good.
polycystic kidney disease, and it is the Bailey's aneurysm, ma'am.
Very aneurysm. In this condition, there is another associated situation or condition. What is that called?
That is, ma'am, the polycystic kidney disease, or
Yes.
Savard-Conner-
Yes.
Yes, polycystic
So
kidney disease.
if in this kind of patient, if this aneurysm ruptures, what type of intracerebral hemorrhage would you expect?
Ma'am, if it ruptures, it produces the subarachnoid hemorrhage, ma'am.
How would that be presented on CT scan? How would you?
Okay.
Yes.
Clinically, the patient will present as the contralateral hemiplegia of the lower half of the face, contralateral hemiplegia involving the upper part and lower part of the body, mostly the upper part one, more affected than the lower part, and there may be development of aphasia if dominant hemisphere is affected, ma'am.
Okay, can you please tell me what is blood-brain barrier?
So blood-brain barrier, ma'am, is a layer, it's a membrane or layer that separates the
It's
CSF
not
from the
membranes.
blood.
Okay. Yes.
Yes, ma'am.
All right.
It
What
actually
is the
separates the-
function of blood-brain barrier?
So function of blood-brain barrier, ma'am, is actually preventing the blood directly entering into the CSF circulation, so that the brain is safe from the toxic structure, toxic substance or chemicals from the in the blood, which cannot cross this barrier and cannot go to the CSF and affect the brain. It is the main function.
Can you please tell me, since the patient has barrier aneurysm, so in what syndrome would you expect patient to develop this pathology, especially when patient has a family inheritance as well?
Yes, ma'am. It is a adult polycystic kidney disease, and due to mutation in the PKD1 and PKD2 gene. And whenever this happens, patient may have multiple cysts in different organs, and associated with this type of connective tissue, and associated with there may be some connective tissue disorder in the blood vessels, which may produce this type of aneurysm.
Thank you. Can you, here are 4 arrows. Can you identify these vessels? I have kind of.
It is left-sided
1,
internal carotid
2,
artery, ma'am.
Yes, and then this one.
And it is the left-sided middle cerebral artery.
This one, please.
This is the anterior cerebral arteries, both-sided, and this is the right-sided middle cerebral artery.
Very good. Okay. Yes. Right. What would be the first line of management that you will carry out for the patient who has barrier aneurysm?
So
and what would be the neurological signs you look for? Yes.
So first of all, I would like to manage the patient according to see if there is any evidence of raised intracranial pressure or not, ma'am. So by assessing a focal neurological examination, at first approaching to the patient according to the ABCDE protocol. At first, I will assess the airway, then I will assess the breathing, the circulation. After the circulation, I will do a focal neurological examination, which actually includes the performing a rapid GCS for this patient, according to the Glasgow Coma Scale, and also performing some focal neurological movement of different limbs of the body and the pupillary light reflex. So if there is any presence of ruptured Berry's aneurysm, so there will be features of raised intracranial pressure. I may find and there may be papilledema, nausea, vomiting. Patient may present as headache, and there may be some kind of defect in lateral gaze of the pupil and oculomotor nerve palsy, and also there may be presence of Cushing reflex.
Yes, good, thank you. All right, so what is blood-brain barrier?
Yes, ma'am, I didn't go through that recently.
Yes.
The blood-brain barrier,
yes.
where it is not available, that was your previous question in the previous sessions, like in certain points, this blood-brain barrier is not available. That was also your question.
I'll go through it. Yes, what does it, it's not the membrane, right?
It's not membrane, it's a barrier,
cells. Yes,
yeah.
Consists of endothelial cells that line the capillaries of the brain. So that differs because it's yes. So you'll read that.
I'll go through it, ma'am. I didn't go through
please.
it.
Good.
Yeah.
Yes.
The functions and where it is not available.
As well. Function is to maintain hemostasis. Okay. In simple languages. So it only allows the entrance of essential nutrients from the blood, and it prevents toxins from entering.
I mentioned about the toxin and the chemical product. Actually, it's showing it is a endothelial cells along with the tight junction present that lie in the neural vasculature.
Yes.
So it will just provide nutrition to the CSF and the brain, but prevention the dissemination of toxic substances into the blood. That's it.
Yes. And the question, when I asked you what would be your first line of management, so first line of management after first survey evaluation, you'll do the CT scan.
Of course, I'll do this. Oh, I see.
Without intravenous contrast.
CT scan, yes.
Yes, very good.
CT scan of it.
Yeah, good. Thank you. Here is your question. 6 seconds left, 5 seconds. Right. So if you have read and understood, considering it critical care scenario, please tell me, how do you define the term pain?
Pain, it is unpleasant sensory and emotional experience associated with an actual tissue damage.
Very good. Okay, can you please tell me, considering it critical care scenario and considering the patient's drug chart, how would you manage the pain of this patient?
Yes, I will manage this patient according to the critical care of surgical outpatient protocol.
Yes.
I will start by assessing the airways and confirming that the patient has a patent airway.
Yes, please keep on telling.
For breathing and make sure that the patient have an adequate analgesia and there is no any respiratory compromise which allow her to unable to cough or expectorate properly. Then I will go for assessing the circulations and confirming that the patient, if there is any relation of the patient status related to the analgesia, if there is any tachycardia or hypertension caused by inadequate analgesia.
Okay.
Then I will assess go for the disability.
Yes.
And there,
considering yes, considering that patient is first post-op day and patient experiencing pain, what are the complications that can occur if you don't get to manage the pain on time?
Complication, yes, a complication of pain. There may be cardiovascular complication like hypertension and endovascular fibrosis, respiratory complications. There will be maybe at respiratory atelectasis due to fibrosis. Musculoskeletal, there may be due
Atelectasis because of fibrosis, all of a sudden because patient is recently operated, so that's why patient has atelectasis. Okay, yes, and
immobility and the high risk of DVT, and also delayed gastric emptying and
all right. Can you please tell me, yes, what do you understand by the term full patient assessment? What is included in it?
The full patient assessment is assessing the short review of the patient, and then after assessing the condition of the patients, I should confirm that if he is taking if the analgesia is effective or not, and if effective analgesia has been given, and if it is proper or not to this patient.
Okay,
and
good.
Then,
can you tell me what is pain pathway?
yes, the pain pathway starts from the pain stimulus, then to A and C fibers. A fibers for the fast sharp pain, and C fibers for the slow dull pain, and then it is transmitted through the spinothalamic tract to the brain stem, bones and the medulla, then to the midbrain, then to the
no, you have to revise this. Okay, can you please tell me some scoring systems which can be used for pain?
Yes, there is a verbal rating score system.
Very good. What is it?
For assessing, categorize the pain like mild or unpleasant, absent, then mild or unpleasant, or discomforting or unpleasant, or excruciating.
Yes.
And there is a numerical scale from 0 to 10, being 10 is the most severe, and there is a visual analog scale by different facial expressions, and the functional assessment of the patient.
In case of patients suffering from pain, many transmitters or neurotransmitters are released. Can you name few from the damaged cells?
From the damaged cells?
Yes. Can you name few substances which are released from the damaged cells? One
Yes,
example, like bradykinin. Any other?
bradykinin, tachykinin, substance B,
Yes,
prostaglandin,
very good. Histamine,
histamine,
prostaglandins. Okay,
serotonin.
very good. All right. Can you please tell me what is, how would you go about and give, what would you give next to the patient to manage the pain?
Yes, after that I should start. I assess if there is a failure method of analgesia for the patient, and if there is any complications, I will discuss this in multidisciplinary team, including a pharmacist,
Yes.
anesthetist, and the nurse staff, and the surgeon, and start giving the appropriate dose of analgesia.
Which analgesia?
The patient has taken paracetamol and COX-2 inhibitor.
Yes.
So
Would you add anything else? This was my question. Okay. Pass.
opioid.
Can you tell me what is the mode of action of paracetamol
Mode of action.
or the mechanism of action? How does it work?
Dose.
Okay. Can you please tell me how would you know if patient has taken overdose of paracetamol?
How would I know?
Yes, please.
If there is manifestations of
Okay. What is WHO's pain ladder? Can you explain, please?
a plain ladder.
Yes, WHO's pain ladder. What is it? Can you explain how it goes, how it increases? It goes from below upward. How do you increase the analgesia? Okay. What is patient-controlled analgesia? Do you understand? Yes, please.
Yes, patient-controlled anesthesia. It is an system where attaching an analgesia to the intravenous to the patient.
Yes.
By a mechanism of pump, the
Yes.
patients by pressing a button, it gives a specific dose. So avoid hyperdose of analgesia to the patient. And it's all to, there is also a valve, a one valve way, which prevent the back way of analgesia back to
Yes.
the to the patient or to the system. Also, there is a one.
Yes.
There is
Can
a
you
one
mention
stoppage.
3 benefits of prescribing PCA to patient?
Yes, 3 benefits. That it is avoid. It is a controlled anesthesia. Avoid 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 overdose of analgesia to the patient. There is a one-way valve which prevents analgesia from giving from back away to the system. And there is a one button system. If he breathes again by accidentally on the buttons, this will not produce an analgesia.
Very good. Okay. Second is COX-2 inhibitor, which patient was taking.
Yes.
Okay. If patient is suffering from paracetamol toxicity, how would you manage that patient?
I will move to. I will shift to another analgesic.
No, patient has already paracetamol toxicity. So
No.
how would you manage management? Okay, you'll revise that.
Okay.
Where would you manage this patient?
How, what?
Where are you going to take care of this patient? In ITU?
In ITU, yes.
Yes, yes, good. So it was random. Your timer starts now, and here is your question. Right. So if you have read and understood,
Yes, ready.
considering its surgical anatomy station, can you please identify structures here? 13, please.
This is 13, cisterna magna.
Okay. 9, please.
9 is the cerebellum.
All right. Okay. 14 here, please. What kind of image is this?
This is the median sagittal MRI
of the brain. Very good. Okay.
T1.
T1. Very good. What is
Yeah.
14, please?
14 is the thalamus.
Okay. 18.
Body of corpus callosum.
Okay. What is corpus callosum?
Can we pass this question, please?
Okay. Can you please tell me what is cerebellar vermis and tonsil?
Cerebellar tonsil is the lower part of the cerebellum.
And more? Anything else about
Pressure
it?
can be no.
Okay.
Just
Can
this.
you please tell me what do you understand by the term cisterna magna or cerebromedullary cistern?
Yes, can be pass this question, ma'am,
Okay.
please?
Interpeduncular cistern? No. Okay.
No.
Can you please tell me about the circulation of the cerebrospinal fluid?
Yes, it starts by flowing through the lateral ventricle, through
Yes.
then interventricular
Yes.
fourth ventricle. Then after that, through two lateral aperture of
Yes.
Loschka and the median aperture of Magendie will go to the from third ventricle to the fourth ventricle, then subarachnoid, then arachnoid villi, then superior sagittal.
Okay. Through arachnoid villi. Very good. Okay. Can you please tell me what is Amol cherry malformation?
Yes, this is a condition of neurological problem characterized by downward herniation of the lower part
Yes.
of the cerebellum, which is the cerebellum tonsil, through the
Yes.
foramen magnum, which leading to non-obstructing hydrocephalus, leading to neurological.
So if
deficit.
you do MRI, how would it appear on MRI? Different? What would be the difference? Yes.
Herniation of the cerebellar tonsil through the foramen magnum, downward level
Okay.
of the cerebellum tonsil. Yes.
All right. You have to read. Okay. What is tentorium cerebelli?
Tentorium cerebelli is a transverse projection from the meningeal dura through which separate between the cerebellum and the lower surface of the cerebellum from the lower surface of cerebellar hemisphere, passing
Basically, anterior attachment.
anterior attachment
Yes,
is
spear angle of
related to the
petrous
petrous-
temporal bone. Yes.
is petrous part of the temporal bone, and laterally
Yes.
and anteromedial anterior colloid posterior clinoid process, posterior pass to the groove of the transverse sinus, and medially forming concavity through which the midbrain is passed.
Okay, can you tell me what are the cranial nerves which contains parasympathetic fibers?
Yes, number 3 and number 7, facial and oculomotor, and glossopharyngeal and the vagus nerve.
Very good.
Parasympathetic fibers. Yes.
Very good. Okay. Can you please tell me if there is a tumor present okay, in the posterior cranial fossa? So
Yes.
where would that be located and what would it compress?
Superior sagittal sinus.
And anything else?
What?
Anything else? Okay, how would you differentiate between upper motor neuron lesion and lower motor neuron lesion of facial palsy?
Yes, as regard the upper motor neuron lesion, it will be affect only the lower half of the face.
Yes.
with sparing of the upper part due to bilateral presentation, but in the lower motor neuron lesion,
Yes.
it will affect ipsilateral,
Yes.
both upper half and lower half.
Yes. Okay. Right. What else can you you want to tell me? Subarachnoid spaces. Can you tell me all the subarachnoid spaces?
Tell me about subarachnoid spaces.
Yes, please. The 4.
For CSF circulation and the flow of the fluid.
No, there are 4 of them.
I didn't get the question.
Supracellular cistern, interpedunclar cistern, propontine cistern, and Lilliquist membrane. So these are the 4 subarachnoid spaces of cistern.
Cisterna, yes, yes.
Yes.
Yes. I didn't get the question about the cisterna.
Okay.
Supracellular cisterna.
What is the
prepontine
function of cerebellum?
cerebellum is responsible for equilibrium and related to the last 4 cranial nerve.
Yes. Okay. Right. Can you please tell me about the contents of the or the boundaries of the middle ear?
The contents of what?
Middle ear?
Middle
the-
ear,
yes, please.
the cavity that is separated from the middle cranial fossa by tegment tympani, superior and inferior,
Yes.
wall
Yes.
separating from the superior bulb of internal jugular vein, and the inner wall separated by tympanic membrane from the inner ear, and lateral wall from the external ear separated, and the anterior wall two opening for stapedius muscle and additus for tubotympanic additus of tympanic canal, and posterior mastoid antrum and stapedius.
Good. What is 17 here in the diagram, in the picture?
This is the sella turcica over the pituitary fossa.
Okay. What is 1?
One is the anterior arch of the atlas.
Okay, good. 5.
5 is the basilar artery.
Okay. 19.
19 cerebral peduncle of thalamus.
All right. 16.
This is the medulla oblongata. 16 medulla oblongata.
Okay. 11 is here on the bottom.
Medulla oblongata. 16 is medulla
11.
oblongata.
11.
11, yes, cervical spinal cord.
Now we'll do right. Now we'll confirm. 11 was cervical spinal cord, very good. 16 you said medulla oblongata, very good, correct. 17 pituitary gland, very good, you were correct. So this picture you know very well, but you have to read little bit about the picture so you know. 2 you said anterior cerebral artery, very good. What else I asked you? 9 cerebellum,
9?
very good, yes.
And cerebellum, yes.
Very good. Okay, 19 is thalamus. So you know this. Very good. Good, thank you.
Thank you, ma'am. Thank you.
Thank you.